Hello, everyone, and welcome to the Impact of Cancer Treatment on Heart Health and the Role of Cardio-Oncology in Survivorship. We're glad you could join us. My name is Elaine Gonzalez. I'm the Community Educator at the Breast Cancer Resource Center, or BCRC. I'm pleased to serve as your moderator today. So here's our agenda for today. Dr. Liu will be speaking until 12:45. Emily Williams will be speaking until 1, and then we will have our Q&A session, which will include everyone. So please make sure to put your questions in the chat box. And thank you for joining us. I think it's going to be a great program. The Breast Cancer Resource Center, BCRC, is a community-based nonprofit serving Central Texans impacted by breast cancer since 1995, strengthened by our mission to empower those affected by breast cancer with personalized support and compassion, and in collaboration with our community partners, BCRC envisions a future where no one faces breast cancer alone. BCRC offers individualized patient-centered care from diagnosis through treatment and into survivorship. Through its two pillars of support, guidance, and education, BCRC's certified patient navigators, whom all are breast cancer survivors themselves, empower those touched by breast cancer to become active and knowledgeable participants in their healthcare journey. This program is provided as part of a cooperative agreement awarded by the Centers for Disease Control and Prevention to expand our programs for young women. The purpose is to increase the availability of supportive services for young breast cancer survivors, young women with metastatic breast cancer, and their caregivers and family. So also joining me is Amanda Ibarra, Texas Comprehensive Cancer Control Program Coordinator and Team Lead. Amanda is going to go over a few slides for us.
Hey everyone, thank you for joining us today. As Elaine mentioned, I am with the Texas Comprehensive Cancer Control Program at the Department of State Health Services. Our program works with private and public partners like Breast Cancer Resource Center to reduce the burden of cancer in Texas. We coordinated cancer prevention and control activities identified in our state's cancer control plan called the Texas Cancer Plan. We also administer a statewide cancer control coalition known as the Cancer Alliance of Texas, and we implement activities that range from primary prevention, screening, and early detection, and cancer survivorship, and also reduce cancer health disparities. Our program does align with the Centers for Disease Control and Prevention's National Comprehensive Cancer Control Program. You can find more information on our website or email us at cancercontrol@dshs.texas.gov. Next slide, please. You can go ahead and go to the next slide, please. So we are happy to be able to offer continuing education credits for this event. In order to obtain continuing education credits, you must complete the registration and sign in, which you are here. So that has been done. Attend the event in its entirety, participate in education activities, and complete the participant evaluation. Next slide. We will be able to offer continuing education credits for multiple disciplines, including continuing medical education for physicians and nursing continuing professional development for nurses. Next slide. As well as continuing education credits for certified health education specialists, certified in public health, licensed professional counselors, licensed psychologists, and social workers. Next slide. Commercial support and disclosure of conflict of interest. All relevant financial relationships listed have been mitigated. Next slide. Non-endorsement statement and off-label use. Accredited status does not imply endorsement of any commercial products or services by the Texas Department of State Health Services, Texas Medical Association, or American Nurse Credentialing Center. The speakers did not disclose the use of products for a purpose other than what it has been approved for by the Food and Drug Administration.
Thank you, Amanda. I'd like to invite Dr. Liu to join us on screen. We are so honored to have with us today Dr. Yan Liu, Associate Professor of Medicine and Director of Cardio-Oncology at Ascension, Texas Dell Medical School, University of Texas at Austin. Thank you, Dr. Liu, for joining us today. I will turn it over to you.
Thank you, Elaine. It's great to be here today. And let me share my slides first, and then, all right. Hopefully, everybody can see my slides, but I want to first thank you and everybody in BCRC for making this possible. And it's definitely my pleasure to be here today to share with you some of knowledge and experience in this fairly new field of cardio-oncology. My hope is that with this, it can really help you to either achieve a better heart health for yourself or help your patient to achieve a better outcome overall. So today, the topic will be the impact of cancer treatment on heart health and the role of cardio-oncology in survivorship. And this is a list of disclosure. And we will be focused on mainly 5 objectives during today's talk. The first one will be the intersections between cancer and heart disease. And then we'll dive into to talk about what exactly is cardio-oncology. We'll be discussing about the scientific foundation and clinical mission of cardio-oncology. And then, as a providers, we'll explain what you need to know. And then for patients and cancer survivors, we will be explaining what you need to know to better your heart health. So first, the intersection between cancer and heart disease. Now, this is the figure that used very often when we talk about the top 2 killers in United States and in most other countries internationally. Those are cancer and heart disease. You can see from heart disease in the last several decades, the mortality rate has been actually peaking and gradually decreasing. But at the same time, the mortality rate for cancer is actually gradually increasing. And these two, what we call rivalry devils, potentially intersect in the future. Now, this is important because when it comes to cancer patients that could have heart disease, we're talking about 2 very complicated disease processes. In the United States right now, it is estimated we have about 16 million cancer survivors. By 2026, the number will get to about 20 million. So it is a large patient population with potentially very complicated disease process and interaction between cancer and heart disease. Also, very important to know that in cancer patients, looking at different type of cancers, the prevalence or incidence of cardiovascular disease are actually very high. Look at the lung cancer. About 40% of those patients could have cardiovascular disease. And this study actually is a huge study looking at 6 million patients using big data approach. And what they find is that in this patient population that has cancer and heart disease, only half, 50% of those actually received the appropriate cardiac care. So in other words, for those patients with cancer and heart disease, at least from heart standpoint, they're very much underserved for their cardiovascular care. A lot of room to improve and a lot of things we can do to improve the heart health in this very complicated patient population. And also very important to realize that in cancer patients, primary cancer is only one cause of mortality or one cause of death. And heart disease has been very often recognized as the most important non-cancer death cause. And in many cancer types, such as bladder cancer, if you look at over here, or endometrial cancer, heart disease actually is a more common cause of mortality or death, especially when the patient is older. More specifically, in breast cancer patients, if those patients have reached 60 years old or above, the actually most common cause of death is going to be heart disease instead of primary breast cancer. So very important to treat heart disease or prevent heart disease at the same time when we treat and prevent cancer. So that's why when we talk about cardio-oncology, when we talk about this outcome in this field, we're actually really talking about the overall mortality benefit, meaning that mitigating the cardiovascular disease in cancer patients not only improves cardiovascular specific, but also cancer specific mortality. And this is also very important to remember, and not only changing the heart disease progression, but also helping cancer specific mortality and progression. Cardiotoxicity very often is talked about during this field, and very often is mentioned in patients, especially breast cancer patients undergoing chemotherapy. And actually, most recently, we have renamed cardiotoxicity as CTRCD. I think every one of you probably will be seeing this word, CTRCD. It really means cancer therapy related cardiovascular dysfunction. It's a broader term compared to cardiotoxicity, but essentially they're actually talking about very much the same thing. So for CTRCD, about 48% of those happens very early, meaning during the treatment for cancer, but 30% of those will be late, way after you've completed your chemotherapy or radiation therapy. What's very important to know is that nearly all cardiovascular structures may be affected, and nearly all cancer therapies could lead to CTRCD. So essentially, we're talking about potentially life-saving cancer therapies that leading to possible life-threatening toxicities. So that's why many experts really think that cardio-oncology is trying to address this very challenging aspect of modern medicine. That is, we have all those life-saving therapies, but they all could potentially lead to very severe toxicity or side effects. And cardio-oncology is really addressing this very exact topic. Very specifically for breast cancer patients, and this is a figure I want you guys to look at it to understand what kind of risk we're talking about specifically for heart failure. So for breast cancer patients who received anthracycline and trastuzumab, what we call sequential anthracycline and trastuzumab therapy, if you look at 5 years after, there's almost 20% of risk for heart failure to develop. And that is very significant. More importantly, or more shockingly, if you look at a relatively older patient population, so this study looking at about 45,000 women, age older than 67, between 67 and 94, this is Medicare data. So if you look at this patient population, 3 years after their cancer diagnosis, almost 42% of those patients will be at risk for heart failure if they received anthracycline and sequential trastuzumab therapy, and which is very common, especially for triple negative breast cancers. So obviously we cannot neglect this type of risk, but more importantly, if you look at inpatient, so for someone, a cancer patient who's been hospitalized in a hospital, if they happen to have heart failure, okay, then the risk of or likelihood of dying during that hospitalization will be almost threefold higher just to have that heart failure as a diagnosis for any reason if they were hospitalized. And then you look at the length of stay, they're about 30 or 40% longer. And obviously the cost of healthcare to take care of this patient population is much higher for the society. Both outpatient and inpatient dramatic impact for this potential cardiotoxicity as heart failure from breast cancer patients. So with that in mind, it's really important to introduce now the concept of cardio-oncology. So what exactly is cardio-oncology? It is a new, very fast growing, it is a cross-disciplinary, it's a collaboration between oncologists and cardiologists. So it's a collaborative subspecialty focused on the management, mitigation, or prevention of cardiovascular disease in cancer patients or cancer survivors to have an ultimate goal of achieving optimal overall patient outcome, not necessarily just cardiovascular specific or cancer specific. It's a whole person outcome, overall patient outcome, which is the most important thing in healthcare right now. So briefly, there's a little bit of history about cardio-oncology and myself being very luckily involved. So the timeline. So first ever mentioning of cardio-oncology as a word in PubMed, which is a very popular, scientific literature website, was back in 1989. And then 20 years later, in 2009, I was lucky to be involved in establishing P16, which is a very famous tumor suppressor gene that really connects the cancer and heart disease. It's the bridge between cancer and heart disease. And in 2015, that's the first time a journal that's designated to cardio-oncology first established. It's called Cardio-Oncology Journal. And then in 2016, the Cardio-Oncology Society, both in Europe and in United States, have established basically the guidelines and also sections for this designated or specialized subspecialty in cardiology. And then by the time in 2019, we start to have fellowships to train cardio-oncologists, which is a program that happens after someone has become a doctor, and then they have to spend 3 or 4 more years to become a cardiologist. Then after that, they have to spend 1 or 2 more years to be trained to become a cardio-oncologist. And then in 2022, that's the first time ever the world has established the evidence-based cardio-oncology practice guideline. And here we now, in 2024. So it is a very new specialty, but it is considered to be the most rapidly growing medicine subspecialty in the world right now. So what exactly is the scientific foundation for cardio-oncology? Now, essentially, it is cardiology or cardiovascular medicine involving all aspects of that as surrounding 3 very important focus. That is, cancer patient have cancer treatment and very unique interaction with the host. And we also know that for cancer patients, the cardiovascular risk factors and the disease process are very different. They're unique. And as we all know, the cancer treatment all could have potential CTRCD or cardiovascular toxicities. And this process, starting at the diagnosis of cancer and going through treatment and after cancer treatment. So essentially, it's a lifelong process, a lifelong preventive and treatment process for this patient population. When we talked about the scientific foundation, we're not only talking about the superficial shared common risk factors or cardiotoxicities or some risk factors. We're really talking about the cancer as a disease process and heart disease as a disease process. They actually have shared fundamental molecular biology mechanism. Think about the same genetic process could either lead to cancer development or possible myocardial infarction or heart attack. That's the type of connection we actually were able to establish between cancer and heart disease. And a little bit more information, as I mentioned earlier, very lucky to be involved in first ever, a group of people that established P16. It's a very important tumor suppressor gene, meaning if you don't have enough P16 in your body, you'll get all type of cancer. It's very similar to P53 for some patients who have Lynch syndrome. That's basically deficient of either one of these genes. So this tumor suppressor gene was established by us to be actually a shared pathway between cancer and coronary artery disease. And almost a decade later, other studies or other groups have shown that yes, there are other processes that could be completely shared by the cancer and atherosclerosis, which is essentially coronary artery disease, such as uncontrolled proliferation, severe inflammation, apoptosis, and etc. We also find out that, for example, in heart failure patients, those patients would actually produce some factors in their body that potentially lead to higher incident or higher risk of cancer development. Very astonishing finding. And then more importantly, this study showed that if someone has heart attack, okay, myocardial infarction, especially if the heart attack is not very well treated, that could actually lead to the acceleration of breast cancer, meaning that heart disease, if you're not treating a heart disease, it could actually lead to the development or progression of cancer. And this is the ultimate connection between these two disease process that really made cardio-oncology so important. To summarize, the same process, the same black box could either spit out cardiovascular disease or cancer. So it's very important to have someone to be able to dissect the process so that we can prevent either or both process from happening, especially to prevent the interaction between these two disease process, which obviously is not ideal and could be very much complicated for our patients. So there comes the clinical mission of cardio-oncology. The first one is early detection of cardiovascular complications from cancer treatment. Second, prevention, mitigation, and management of cardiovascular disease or cardiotoxicities in cancer patients or survivors. And really, we're aiming to enable the optimal cancer therapy at the same time where we can minimize your cardiovascular disease risk so that the patient can achieve overall patient outcome through this multidisciplinary care strategy. And this is the picture I want to show you, even though it's a little bit complicated, but essentially this in the middle, the center is the oncology care. So you have your medical oncologist, surgical oncologist, radiation oncologist, all of them surrounded and supported by their team, oncology pharmacist, their nursing staff, all of that, to take care of the cancer itself. But at the same time, here's us, the cardio-oncology service or cardio-oncology service line. In our situation, we have cardio-oncologists, we have vascular oncologists, we have nurse practitioners, we have coordinators, very important. We have cardio-oncology pharmacists and advanced heart failure specialists. They're all here to actually support the oncology care unit so that we can better help you through this multidisciplinary approach. And this is very important because collaboration is the key. So as providers, what do we need to know for cardiotoxicity or CTRCD? I want to dive right into these two very notorious agents. One is anthracycline, the other one is trastuzumab, because they are the most discussed and also most commonly asked, agent or targets. So we all know, and I think many of you may have give your patients, or many of you may have actually have exposure to anthracycline, such as doxorubicin, etc., for a very effective cancer treatment, especially for triple negative breast cancer. The reason for this agent could potentially have a risk of heart failure or cardiomyopathy is because it is actually have an effect of direct killing, meaning the reason this is so effective when it comes to treating cancer is because it could kill cancer cells directly. But at the same time, this process could happen in much milder extent to the muscle cells. So look at on the left side here. So look at on the left side here, this is the electric microscope of the muscle cells in your heart. This is normal. And then after anthracycline, some of the cells could actually die, become like this. And then the body will graduate to remodel, rebuild, just like a house after, a tornado. And the heart is usually very good at rebuilding or remodeling, and so that it can normalize the muscle cells. But this rebuilding process sometimes could go off track. That is why sometimes cardiomyopathy or heart failure could happen. Very differently, when it comes to trastuzumab, a very common agent for breast cancer patients. the mechanism of trastuzumab potentially could cause heart muscle dysfunctions actually through receptor interaction, because it is what we call an anti-HER2 agent. But HER2 cell not only is expressed on cancer cells, some of that could be also expressed on heart, what we call cardiomyocytes. So this interaction off target could lead to potentially cardiomyocyte dysfunction. Luckily, most of the time, this dysfunction could be either milder compared to anthracycline, or a little bit easier to be reversed if there's truly a cardiotoxicity developed. So there comes the two very different but very important mechanism for the chemotherapy could potentially cause heart failure or cardiomyopathy. But the possible cardiotoxicity or CTRCD are way beyond cardiomyopathy. So we talked about cardiomyopathy earlier, but some other agents such as checkpoint inhibitor or immunotherapy could cause myocarditis, inflammation of the heart muscle. They could lead to coronary ischemia, essentially not enough blood flow for your heart muscle, which could be dangerous because that could be a pre-drone of heart attack. They could also lead to potentially arrhythmia or abnormal heartbeats, such as atrial fibrillation. And some other agent, as we talked about, they potentially could have a risk of heart failure at different level. Meaning anthracycline or trastuzumab, they're commonly known could potentially cause cardiomyopathy. But other small molecules, target therapy, they all could have smaller but real risk for cardiomyopathy too. And then when you talk about some of the risk factor for heart disease, such as high cholesterol, that could be caused by some of the hormone therapies, hypertension, if some patients have received Avastin, some of the tyrosine kinase inhibitors or anti-VEGF inhibitors, all those could potentially lead to very tough to control high blood pressure that often needs extra medications due to therapy. Sometimes some other therapy could cause hypotension or low blood pressure. Some of the very effective target therapy, such as the dasatinib, could potentially lead to pulmonary hypertension. That is a type of condition that you have high blood pressure in your lung. Many agents could potentially increase your risk of blood clot in your artery or in your vein. And radiation therapy, especially when it comes to left-sided breast irradiation, could potentially lead to heart valve disease or pericardial disease. That means the heart sac having inflammation or hardening down the road. And usually the radiation, the side effects or cardiotoxicity from radiation only comes late. Late toxicity usually is 5 to 10 years down the road. So, so all those toxicities, how do we manage, how do we tackle those possible cardiotoxicities? I think it's very important for either some providers or patients to know that this is how we actually really take care of you or really prevent things from happening for you. That is the treatment stages for cardio-oncology. We really focus on the primary prevention, meaning that even before you start any chemotherapy, we will be actually looking at all the cardiovascular disease risk factors. We would love to control them. And that's why a lot of patients come to my office. You will be asked a bunch of questions for screening purpose. And that is to aim to basically find out what other risk factor you could have that you may not even know. And then besides that, we may actually at that time recommend medications for high-risk patients to optimize your primary prevention. Then after that, we'll be focused on the early detection of preclinical. What is preclinical? Basically means that before things even happening. So we wanted to detect very subtle changes that could potentially lead to cardiotoxicities so that we can prevent things from happening. And then later on, if some patient unfortunately developed some cardiotoxicity or CTRCD, but they're asymptomatic, we have very good strategy to prevent them from progressing to the next stage, which is overall cardiotoxicity or symptomatic cardiotoxicity. And even in that stage, we can have medical therapies or interventions to help you either prevent the disease process from progressing or reverse the possible CTRCD or cardiotoxicities for you. I want to give you an example in terms of how we actually treat or how we, take care of patients who's going to be on anthracycline, such as doxorubicin. So we start at baseline. So patient will come to our office before they even start anthracycline therapy. We'll be getting an echocardiogram, making sure their LV ejection fraction, the percentage, it's more than 50%. We'll be getting a 12-lead EKG in office. We'll have a very thorough cardiovascular risk factor assessment. We'll be checking biomarkers. We may screen them for other risk factors. And then we'll give a recommendation to the oncologist in terms of how they do it, if they need dose reduction, if they need to actually involve other cardioprotective agents during treatment. And then during treatment, we'll be seeing this patient very frequently. We'll be using echo to screen those patients, and also is true for biomarkers. And then, for example, if the patient's heart function reduced to below 50%, we may talk to your oncologist to design a strategy to give your heart a rest so that you can recover, regroup before you restart a therapy. And at times, if some unfortunate patient that have heart function reduced below 40%, we may talk to your oncologist to have a shared decision-making with you to think about other options of therapy, because at that time it may be too dangerous or unsafe to continue the anthracycline. And after treatment, usually 6 months to a year, depends on your risk factors, we'll be screening you, assuming your heart function is normal during the treatment process. And then this process will be lifelong for every 2 to 5 years. So as a provider, either a primary care physician or maybe some oncology colleagues here. Very often the asked question will be, when do we refer this patient? So here's a summary of when to refer to a cardio-oncologist, one of which is suspected or confirmed cardiac dysfunction related to cancer therapy. Or if you find that the patient has an abnormal cardiac study, such as EKG, such as echo or stress tests, or just biomarkers, even though they don't have any symptoms during therapy, that will be a great time frame for us to see this patient so that we can initiate primary or secondary prevention. Obviously, if some patient has very high cardiovascular toxicity risk factors, then optimization will be ideal, done by us. For patients who already have a history of cardiotoxicity, the secondary prevention is essential. Feel free to send those patients to us. And obviously, for cancer patients who have very significant cardiovascular disease or a condition or history, those are the patients who will get a lot of benefit from seeing us. If some other patient is going to be going through some, phase 1, phase 2 clinical trials, and some of those trials are very much cardiotoxic, and then preclinical trial cardio optimization is something we do all the time for UT, for MD Anderson. So feel free to involve us if desired. If in case the patient will have a primary or secondary cardiac tumors, not very often, but those are the patients we've seen will have to manage. Some patient, if they have multiple myeloma, they may have suspicion of cardiac amyloidosis, which is a condition very tough to treat. And we are actually very much expert in those fields. We do actually heart transplant for those patient populations right here in Austin. For childhood cancer survivors, they are a very important patient population because their life expectancy is very long. So the longer they live, the higher the risk for them to have cardiotoxicities from early exposure to some of the highly toxic chemotherapies. So this is the summary of when to refer. So what about as patients, what do you need to know? Well, cardiotoxicity, or when you will be concerned about that you have some risk or you are relatively high risk for cardiotoxicity. So here are some very common risk factors for potentially cardiotoxicity, or we call cardio-oncology risk factors. If you're age 60 or above, you'll be a little higher risk compared to younger patients. If you have a history of hypertension, high blood pressure, high cholesterol, diabetes, or you have family history of cardiomyopathy or heart failure, those are risk factors. If you have a different lifestyle, you are smoking, or you have a long history of smoking in the past, if you have alcohol abusing history, or if your BMI is really high, those are risk factors. If some doctors in the past told you you have heart function reduction or low normal heart ejection fraction, those are actually very important risk factors to recognize. If you have a pre-existing structural heart disease, such as heart valve disease, heart chamber dilation, that also is a very important risk factor to recognize. If someone has already have doxorubicin or anthracycline exposure, especially more than 250 milligram per square meter, those are very important risk factors that to recognize. Potentially those patients all should be seen at cardio-oncologist. If someone had a high dose radiation, more than 30 gray, which is really the dose can kill a mouse. So those are the type of risk factors you really want to recognize and talk to someone about. We talked earlier about sequential anthracycline trastuzumab therapy history. Those are very, very important risk factors for you to recognize. So what exactly is the definition of cardiotoxicity? Since I've been talking about this CTRCD and cardiotoxicity all this lecture so far. So what is the definition of it? It's actually very simple. First, if you have symptoms or signs of heart failure, what are those? Severe short of breath, that's new, either at rest or with exertion, or what we call orthopnea, meaning when you lay down, lay flat, you suddenly find yourself just cannot breathe. And those are type of symptoms of heart failure. If you find yourself to suddenly have fluid accumulation, leg swelling, swelling your arm, fluid retention, all those could be signs of heart failure. Or someone just having chest pain, waking up coughing, waking up trying to catch breath at night, all those could be warning signs or symptoms of heart failure. However, some patients, if they don't have any symptoms or signs of heart failure, they're asymptomatic, but if their LV ejection fraction, so LV function, that is left ventricle heart function, if the reduction is more than 10% relatively to below 50%, obviously your doctor should know this a little bit better, but that's kind of the definition. If you have that, that is considered to be a CTRCD or cardiotoxicity. Or someone has an absolute reduction of left-sided heart function for more than 16% from pre-chemotherapy level, that is also considered to be cardiotoxicity. Now, this is the type of information I want you to get an idea about, but I really want you to talk to your doctors, especially your cardiologists, your oncologists about for clarification. So I think the most important to remember is if you have those symptoms, and then you really wanted to talk to someone, okay? So then the next natural question is when or who needs to see a cardio-oncologist? For patients have those cardio-oncology risk factors we just talked about, or they have been exposed to, or they're having ongoing high-risk cancer therapies such as anthracycline, doxorubicin, trastuzumab, and etc. For cancer survivors, especially childhood cancer survivors, as I mentioned earlier, so childhood cancer treatment usually involves highly toxic chemotherapy that's very effective. And because their life expectancy is expected to be very long for those patients, so their accumulated risk actually is much higher. So those patients are very important. You basically want to really talk to your survivorship providers to raise the question. Actually, most of survivorship, like many in Central Texas, they already integrated cardio-oncology as part of their care. So for heart patients, if you're a heart patient, you have cardiovascular condition already, and then you suddenly find you have cancer, you need to be treated for cancer. So those are type of patients that you potentially want to consider to see a cardio-oncologist. Then the other natural question will be, what if I already have a cardiologist? Well, in general, regular cardiologists may not be familiar with new cancer treatments or their heart-related side effects. So many of my patients, they have a cardiologist, but they do come to see us as a cardio-oncologist so that they can get optimization doing cancer treatment, and then they can go back to their regular cardiologist after the cancer treatment is completed. So there's no confliction or overlap between these two specialties. So many of you may ask that what would happen if I go see a cardio-oncologist? Also, during your visit, the cardio-oncologist will review your cancer and heart-related medical history. They will ask you a lot of questions about possible symptom of heart disease, including some of I already discussed earlier. And then after the visit, they will be talking about some of the potential tests, including EKG, usually done during the visit, or echocardiogram, it's ultrasound of the heart, and sometimes maybe stress testing, sometimes maybe heart MRI. And those are really, the purpose of those tests are to check in the heart pumping function, the blood flow to the heart, or sometimes to make sure you don't have heart rhythm problems. And sometimes the blood work or what we call biomarkers may be needed to help you to optimize your heart health during the same time. And then finally, the cardio-oncologist will talk to you about possible strategies, either long-term or short-term, to protect your heart, including some of the very important lifestyle changes with diet, exercise, and etc. And then many of you will be having follow-up visits with us, with the cardio-oncologist, and some of those sometimes the relationship is actually lifelong, every year or every 6 months or every several years. So with that, I think the final slide I wanted to really, to conduct to especially our patients. That is, after this talk, so what kind of question I should ask my providers, my oncologist, my cardiologist, or my primary care physicians about my cardio-oncology health or about my heart health if I have cancer. So the first question I want you to ask is, am I receiving or have I received any cancer treatment that could affect my heart either now or in the future? Secondly, what are my risk factors for developing cardiac side effects from this treatment? And then ask them, do I need to see a cardio-oncologist during the treatment or after treatment? And then if my cancer treatment could damage my heart, how will my heart be monitored during this process of treatment or after the treatment is completed? I think those are the questions to talk to your providers so that you can have a much better understanding about your treatment for yourself, and also that can facilitate potentially a collaboration between the providers if you're not yet seeing a cardio-oncologist. Again, I hope this information as a whole can help you to either achieve your better heart health or help your patient to achieve a better overall outcome. I want to thank you for your attention. And now I'm going to hand it back to Elaine. I'll be stopped. All right.
Thank you, Dr. Liu, for that informative presentation. That was so great. Dr. Liu will be back with us at the end for the Q&A session. So make sure you drop your questions in the Q&A box. So I'd like to introduce our next speaker. We're so honored to have with us today Emily Williams. Emily is a breast cancer survivor and a mom of two. She is going to talk to us about her story and experience with cardio-oncology. Thank you, Emily, for joining us. I will turn it over to you.
Sounds good. Thanks, Elaine. So I kind of want to start off by giving you a bit of a background about me. I've always been active, played sports all throughout high school and college, and always made it a priority to work out multiple days a week. Over the last 10 years, I really got into running. So I have run over 100 marathons, half marathons, and even an ultra marathon. So I set a goal to run in all 50 states. And so prior to diagnosis, I had knocked out 30 of those states. So all this to say that I never imagined having to worry about my heart health for the foreseeable future. Then cancer hit. So I had just turned 40 and got my first mammogram, which came back clear. My husband and I had gone through 7 rounds of IVF and already had a 3-year-old daughter as a result. And so we knew we wanted one more child. And so we transferred one of our frozen embryos about 2 months after that initial mammogram. So that embryo stuck and I was pregnant. The happiness surrounding the pregnancy, however, was short-lived. A few weeks later, I felt a lump in my breast. And at first I thought it was an oddly timed clogged milk duct, but just in case, I mentioned it to my OBGYN at my next appointment. And she immediately referred me to get an ultrasound. And the radiologist biopsied the lump. And a few days later, I got the diagnosis that it was breast cancer. So at this point, I was about 9 weeks pregnant when I met the oncology team at Texas Oncology. The tumor had grown pretty quickly, over the course of those 4 months since my clear mammogram. They were estimating that the tumor was around 5 centimeters. In hindsight, that kind of makes sense. That the tumor was growing quickly because, as with IVF and trying to sustain that pregnancy, I was injecting myself daily with progesterone and estrogen. So being pregnant with cancer, my recommended treatment wasn't different from a non-pregnant cancer patient, except for the timing of my treatments. So I started with the single mastectomy, which we later waited until it was a few weeks into my second trimester to do, as surgery is safest during the second trimester. Now, a few weeks later, I started chemo. So I started with the 4 rounds of AC chemo spaced out 3 weeks apart, and then moved on to 9 weekly rounds of Taxol before my water broke. And I had a healthy baby girl via C-section, and a few weeks later wrapped up my cancer treatments with 6.5 weeks of radiation. Admittedly, I didn't have much in side effects with chemo. I only really experienced fatigue, which got worse and worse with the compounding effects of chemo. And then by the time I went through radiation, I was tired quite often, though it's hard to say whether that was the radiation or if it was having a newborn, but I associate it with radiation. So throughout my cancer treatments and up until the day my water broke, I worked out 6 days a week. I was mostly doing high intensity interval training, boot camp classes. I also ran a 10K while pregnant. Exercise was my stress release during treatments. It gave me a sense of control over my body, but also provided me with some stability and normalcy during a time filled with medical appointments. It also gave me a supportive community as well. So exercise also helped me significantly in overcoming a lot of the negative side effects of chemo. I feel like, I was hydrating more, and so that helped to kind of flush the toxins out of my body. So to keep me motivated to continue working out, even on those really tired days, I set a goal to run all 6 of the Abbott World Marathon majors. I'd already run 3 of the marathons prior to my cancer diagnosis. So I just had London, Tokyo, and the Boston marathons left. So I signed up for London Marathon while going through chemo. The marathon was scheduled for April 2023, 3 weeks after I was going to complete radiation. Marathon training started, and when I started radiation, because I was not going to run when I was 35 weeks pregnant, and it was hard. At that point, my body felt weak from the 13 rounds of chemo. Radiation made me feel even weaker. A 3-mile run used to be easy for me, but now, I would have to take walk breaks every couple of minutes during my training runs. I felt more winded. It felt like I was carrying lead weights with each step. It actually made me feel dejected during training because I constantly in my head was worrying whether or not I could actually finish the marathon. But I kept going, kept with the training. I didn't want to fail my friends and family who were supporting and rooting for me. So I traveled to London. It was my kid-free vacation early on when we had the newborn. The marathon was still hard despite my training, and my body still wasn't recovered from the chemo and the radiation. But I gave myself some grace and, took my time 1 step at a time. And eventually I did cross that finish line at the London Marathon. So once I got back to the States, that's when I started taking a PARP inhibitor called Lynparza and a hormone blocker, letrozole. I also had a full hysterectomy when I came back because I was BRCA2 positive as well. So as I was starting to feel better from the effects of chemo and radiation, the 2 medications and being on surgical menopause brought on the muscle fatigue and the joint pain. I continued with the weightlifting, the boot camp classes to help combat, any osteoporosis that can come with early menopause. And then also to keep me motivated to stay active during that really hard time as well, I registered for both the Tokyo and Boston marathons. So earlier this year, and 1 year after finishing my cancer treatments, I completed my world marathon majors journey and crossed the finish lines in both Tokyo and Boston. Now that you got a sense of my diagnosis, my treatment protocol, and why heart health is important to me with all my running and then supporting my active lifestyle, I want to share how cardio-oncology played a role in all of this. The first time I heard that chemo can negatively impact my heart was right before I was about to start chemo. My medical oncologist at the time referred me to get an echo to get a baseline before we started chemo of like what my heart had looked like. Honestly, at the time I was a bit thrown off by all this. This was the first time in my life that I'd heard that my heart health could be negatively impacted. And as a 40-year-old active individual, it was never in my radar to have to worry about my heart health. I thought I had at least 20 years before I had to even consider anything with heart health. But, admittedly, heart conditions do run in my family. Both my parents have, hypertension. And so something definitely I knew was probably coming down the line, but not in the near future. So about 10 months after I finished cancer treatments and while training for the Tokyo and Boston marathons, I brought back up the chemo impact on heart health with my medical oncology team. It was my medical oncologist at Texas Oncology who referred me to Cardio-Oncology, specifically saying that this doctor has worked a lot with cancer patients and is well versed in the impact chemo has on the heart. If I hadn't mentioned personally to the medical oncology team, I don't think I would have ever been made aware that cardio-oncology existed. So when I made the appointment with the cardio-oncologist, I felt fine for the most part. I hadn't noticed any issues with my heart in my day-to-day or in any strenuous activity. The only feeling I had was greater difficulty in breathing than what I was used to during exercising. My blood tests were also showing higher cholesterol. So between these two is kind of what motivated me to bring it up in that appointment with my medical oncologist, and then ultimately to make that initial appointment with my cardio-oncologist. Overall, though, going into the appointment, I wasn't overly concerned that the doctor would find anything, but just like cancer, you never know, right? And just like cancer, it's also, I know it's new, it's beneficial to be extremely proactive and catching any issues earlier than later. So ultimately, between all that, that's what motivated me to make that appointment. Going into that appointment, I had some fear looming in the back of my mind that the doctor would tell me that there were issues with my heart and that it would be unsafe to run in the marathons. But again, at least I was being proactive, and I guess better to know now than have something bad happen during the marathons. So at my first appointment, the doctor mentioned doing some initial tests. He said we'd have to do an echo. I did a stress test. And also I wore a continuous heart rate, heart monitor for a few days after the appointment. But I thought, great, we're getting a full workup of various tests. I definitely appreciated the more thorough approach. But also one of the things that's hard as a cancer patient is how many medical appointments we have. I know anyone who's going through cancer or a survivor can empathize, but that's oftentimes my hesitation with making an appointment with any referrals that my medical oncologist has. Including travel time, I end up having to block out 3 to 4 hours of my workday to attend these appointments. And some weeks I end up having 2 to 3 appointments and ends up taking up a good portion of my work week. Also, cost is a factor as well, which is why I might hesitate making an appointment with a cardio-oncologist, especially if I wasn't currently experiencing any heart issues. Personally, I have pretty good health insurance through my husband's employer, but I still have a $50 copay for every visit, along with any associated co-insurance costs for subsequent tests. So when I made my first cardio-oncology appointment early in 2024, I still had a lot of my FSA dollars available, which is why financially I was okay with making the appointment when I did. Admittedly, I had never done a stress test or worn a continuous heart monitor before. The monitor wasn't bad. The adhesive got a little itchy towards the end, but I liked that it stayed put through all my activities. And it was easy for me to drop in the mail after the few days were up. And as a runner, I thought the stress test was a fun challenge. I thought it'd be much easier than it was, running on a treadmill. But I was definitely huffing and puffing towards the end with, as it got faster and the incline got steeper. Guess I should work on my hill training a little bit during my marathon training. But anyway, the echo was a bit painful. However, having gone through reconstruction, and I have implants now as part of my reconstruction. So the implants kind of made it more difficult to get some of the images with the ultrasound wand. But ultimately, a month later, I had a follow-up with the cardio-oncologist, and he gave me the "everything looks good" message. So I'll take it. The one thing that the cardio-oncologist did tell me at my first appointment was to consider making Boston my last marathon. So personally, I was already thinking that, Boston would be my last marathon I would run. So fine. But I was also thrown off since running feels like it's ingrained in me now. It's just helped me get through all my cancer treatments. It's helped a lot with the stress levels and overall keeping me in shape, which is huge with hormone blockers, is definitely adding on the pounds. So I felt kind of a bit saddened when I heard that, and thinking about the thought of giving up running. So, I interpreted his message as you can give up the marathon distance, but, half marathons and anything lower than that's fine. So that's how I'm taking it. Hopefully my doctor agrees with me. Anyway, so hopefully sharing with you my background and my journey has given you a sense of why heart health is important to me, and how I never thought as an active 42-year-old that I would ever have to think about heart health at my age. But today, I'm 2 years from when I started my cancer treatments, and I feel great. Cardiovascularly, I'm doing well and feel like I'm back to my pre-cancer levels. I still have the lingering joint pain, but I think this is my new normal at this point. And, like Dr. Liu said, I'm set to follow up with my cardio-oncologist in a year from now, and cross fingers, everything continues to look good. So that's my story, and thanks for giving me the time to share it with you all.
Thank you, Emily. Thank you for sharing your story. That was very powerful, and you're amazing. I'd like to invite Dr. Liu to come back on screen with us. We do have time for some questions. And so, Emily, I also there's some great comments in the chat box. So we'll get to some of those here before we end. Okay, so first question, and continue to put them in the Q&A box. We'll try to get to as many as we can within the next 12, 13 minutes. So Dr. Liu, first question, what type of symptoms should physical or occupational therapists keep in mind as triggers to refer to cardio-oncology specialists? Also, talking about screening questions for cardiac side effects as well.
Great. So I think for physical therapists or OT, PT/OT providers, very often they have to kind of make the patient to exert themselves. So short of breath, especially if it's autonormal with exertion, that's one of the very common symptoms. And if the patient feel dizzy, feel like they're gonna pass out, or they passed out during the process of treatment, that is for sure something that they need to see a cardiologist or cardio-oncologist about. Very often, the providers will notice some irregular heartbeats or possibly arrhythmia. during workup. So those are the type of the symptoms or signs so if they can recognize and potentially talk to patients, current providers, or potentially, introduce them to cardio-oncology service, especially if the patient is actively receiving chemotherapy or radiation therapy.
Okay. Let's see. Is there a greater increase in a specific type of BCA?
Sorry, can you repeat the question again?
Yeah, so is there a greater increase in a specific type of BCA? And she has lobular, ductal, etc. So I'm assuming she's meaning actual diagnosis.
So maybe the question is that is there any specific increase in cardiotoxicity when it comes to different type of cancer? Great question.
And also I think she added is also is this prevalent in both males and females? So
Yeah, so let me answer the second question. In terms of the incident or prevalence of cardiotoxicity, they're similar and they are actually not gender specific. However, they could be risk factor specific. Like I mentioned in the last few slides, if age, other risk factors such as high blood pressure, high cholesterol, diabetes, or if you already have exposure to some of chemotherapy in the past, those could be the reason someone could have higher risk or lower risk for cardiotoxicity or CTRCD. So gender is not a significant role or factor in that. The first question, I guess, is different cancer or different breast cancer types, and would they have a correlation with cardiotoxicity or CTRCD? The answer usually is no, because it really depends on the treatment strategy. So I would say, different type of breast cancer may require different type of treatment, and then the different type of treatment may lead to different set of risk profile for cardiotoxicity or CTRCD instead of just a different type of cancer.
okay. I do want to ask a question for Emily and actually for both of you. So, Emily, what did you feel? I mean, were there fears when you first were given the information about you could possibly have heart issues, in the future from treatment? How did you feel? And Dr. Liu, as a follow-up, what do your patients say when you see them? So I'll let you go first, Emily.
Okay. Yeah. Thanks, Elaine. So working out is like second nature to me. It defines me and it's who I am. And so the thought of just having heart issues that would hinder my ability to go and work out and stay active and continue what I love doing was a hard pill to swallow for me. And I almost was in disbelief and like, oh, this can't happen to me. But it was really hard. But with my parents and their heart issues that they have, I'd rather know now, right? Like I'd rather not find out like too late in the process. So it's like if there's something I can do now to help myself for the future, I will gladly do it. But yeah, it was hard. That was just as hard as almost I feel like getting the cancer diagnosis, I mean, like just hearing that. So
Wow. Okay. Dr. Liu, what do you hear from your patients?
I think it's very similar to Emily. By the way, Emily is absolutely inspirational. Like she has, tell her story about it. So, she's and the patient like her is really the reason we're doing this. And we learn a lot. Both myself and my team learn a lot from our patients. So, very similar to her response. Really, a lot of patients coming in, they're kind of in shock. So like, I am, so healthy. I've done everything right in my life. Why am I concerned about my heart? It's like my heart should be the one thing that's absolutely should not be affected, because I'm so healthy. So that is very typical and it's a completely understandable response. But the one thing I want you to keep on, if some of the patients in the audience is that it's very important to know that the majority, if not all, of that type of visit or care is preventive. And prevention, very unfortunately, very oftenly being neglected in modern medicine, is the most important type of treatment for any type of disease. And then when it comes to cardio-oncology, it is essential. So essentially, we're here is to optimize your risk profile and to potentially help you to detect things very early, extremely early, so that we can prevent, some of the, unimaginable outcome from happening. So you really are doing all preventive cares together with your cardio-oncology team. That concept is essential, and the part that you cannot control is what type of chemotherapy or radiation therapy you're going to be on. So it's really not because your history or even your family history has led to any of those things, but rather the need of eradicating the cancer requires us to make sure we have your heart protected.
Mhm.
So that is it's think about going to a war with some good equipment, right? That's We're here to serve you so that you can be extremely successful during this fight against cancer.
Absolutely. Absolutely. I like this question. So, would it be recommended for a patient to have a visit with cardio-oncology to establish a baseline before treatment even starts? So you have results to compare to at the end.
Great question. That's actually the what we call standardized care when it comes to cardio oncology. Most patients, especially if they're going to receive some possible like cardiotoxic treatment, most of those will come to our office to seek consultation before the treatment starts. Yeah, obviously depends on your risk profile, depends on your regimen of cancer treatment. Your oncologist may think that, hey, you're relatively low risk. In that situation, you may not need a cardio oncologist. So in that situation, you may not see them, unless something really happens. Obviously that possibility is very low. But when it comes to individual patients, sometimes that risk does, it's really means nothing, because when it happens to a patient, that risk is 100%. So really, I think in general, that is the case, but it's a very good question.
Great. Let's see here. Um, are the guidelines for cardiac follow-up available somewhere? NCCN seems to be very vague, especially for patients that are 5+ years out of treatment.
Yes. So NCCN, is one of the resources for that, but the more comprehensive resource will be the cardio-oncology specific guidelines. So the patient can search on, you can Google even 2022 cardio-oncology guidelines. You can Google that, and you'll find that in 2022, our society, the cardio-oncologist, have put out the first ever evidence-based practice guidelines. You can, refer to that. And then my recommendation will be you can read about it, but definitely talk to healthcare providers so that they can help you to interpret it or just, help you to clarify.
Perfect. Um, this is a little bit long, but I think it's a really great question. So she says, Dr. Liu, this is excellent. What about women with poorly controlled HTN due to lack of healthcare access at the time of diagnosis? And she does have an example, a woman with newly diagnosed HER2 positive disease needing cardiotoxic therapy and uncontrolled HTN, tobacco dependence, obesity, etc. Would you like to see these women, or would referral to a general cardiologist be more appropriate?
Yeah, this is actually exact type of patient we see and we help to optimize. Uh, that means basically uncontrolled cardiovascular risk factors, like she, like this patient mentioned, hypertension, smoking. Those are the exact the patient we will see, we will optimize we will talk to the oncologist about so they can find the best timing of therapy after we get their risk factor optimized. And some therapy, as you know, many of you know, that could actually make your hypertension or high blood pressure worse. And I think, when it comes to smoking, it is essential to know that stop smoking or quit smoking is way more important than seeing a cardiologist. That's what I tell my patient, because that's a simple one of the best thing you can do for yourself. But we also understand that the road is not easy; it's tough, and we help those patients in different ways so that they can achieve the better health for themselves, especially if they're going to go through some potentially cardiotoxic treatments for their cancer.
This is actually from Kimberly Ellison. She is a nurse practitioner here in Austin, and she says y'all share some of the same patients, and so she says the patients really love you. So thank you. And we also got another comment that said
Thank you,
for
Kimberly.
your
We
time.
appreciate that.
Yeah. And so we got a lot of appreciating and thank yous. Okay, so that is all the time we have for questions right now. I'm sorry we didn't get to all of them. We have just about a minute left. So I do want to say thank you again, Dr. Liu, for your expertise, for a wonderful presentation. And thank you, Emily, for sharing your story. I think it really helps the medical professionals understand where patients are coming from, and so they know how to approach this topic better, I believe. So thank you for that.